Hello and good afternoon. Thank you all for tuning in today. My name is Ryan Boyles, owner and editor of Health News Illinois. We have a wonderful panel with us today to give us a look at the current state of rural healthcare in Illinois and highlight some of the steps that are being taken to address the challenges faced by both patients and providers. Thank you so much to our esteemed speakers for sharing some of their valuable time with us today. I am thrilled to introduce Tracy Warner, the Executive Director of the Illinois Critical Access Hospital Network, Molly Peters, the Public Health Administrator for the Greene County Health Department, Kim Matroka, President and CEO of the Christopher Rural Health Planning Corporation, Dana Kelly, the Chief of Staff for the Department of Healthcare and Family Services, and I'm not sure if he's on the call just yet, but Dr. John Flack, the chair of the Department of Internal Medicine and Population Science and Policy for the SIU School of Medicine. Oh, I see Dr. Flack there now. Hello. Good afternoon there, sir. Um,
Hello.
Before we get started, I want to thank the generous sponsors of the Health News Illinois event or virtual event series. These important discussions would not be possible without their support. So, a huge thank you today to Molina Healthcare and United Healthcare. Additional slots are still available to sponsor our 2026 event virtual event series. If you're interested, please contact me at rvoyles, V as in Victor, Oyles, at healthnewsillinois.com. Health News Illinois is an online, nonpartisan news service. In addition to hosting events like this, we also publish a daily email newsletter. If you're not a subscriber, I encourage you to sign up for a free trial. You can do so on our website at healthnewsillinois.com. With that, let's jump right into the discussion. And just to set the stage a little bit, rural healthcare in Illinois is at a crossroads. Medicaid revenue is expected to drop in the coming years. We're seeing healthcare deserts, OBGYN deserts are widening, and provider shortages persist. So, what does this all mean for the future of care in Illinois' less populated regions? Will more hospitals and organizations band together to stay financially solvent? And how are providers adopting technology? And what kind of impact will that have on the workforce challenges? There's a lot to unpack there. And hopefully, over the next hour, our panel will be able to help us pack some of that. And Tracy, I want to start with you on this, and I will go to each of our panelists with some variation of this question. But from your perspective, just what is the state of rural healthcare in Illinois right now?
Sure. And thank you, Ryan, for the invitation to be here today. And thank you for the fellow panelists and all the people that are joining today in this topic, obviously, of importance not only for access to healthcare, but the economies of our rural areas. And I would say that rural healthcare in Illinois really is at a crossroads right now. And our membership through ICANN, we have some of the most mission-driven hospitals in the state, often the largest employer and the only source of care for miles, but they're operating in a very challenging financial environment as well as workforce environments that we've ever seen. Financial strain, of course, is the single biggest threat today. Illinois rural hospitals are heavily dependent on Medicare and Medicaid. That's often 70 to even 80% of their payment mix. So it means that they're extremely vulnerable to low reimbursement, payment delays, Medicare Advantage denials. Many hospitals are seeing growing volumes, but shrinking margins, I should say. That's due to inflation, drug costs, contract labor, cyber and IT security expenses continue to rise very quickly. Workforce crisis is still there. Recruitment remains a challenge. I will say, though, that most rural hospitals in Illinois are still there. They're still delivering essential services. Stability can be fragile depending on the community. We know there are OB closures, behavioral health gap accesses, limited specialty coverage. All those issues continue to grow. A hospital may, need to look at how they need to move forward. They're not standing still. They're advancing in technology, for example, to combat some of these issues like telehealth and care coordination, value-based care, cybersecurity, digital infrastructures. And we'll talk, I believe, or I'm positive we'll talk some more about the transformation program and other state and federal initiatives that are becoming available because that transformation is really no longer optional. It's necessary for survival. But just as a bottom line, I would say that from my perspective, rural healthcare in Illinois today, the story is it's not one of collapse, but it's one of high risk and high urgency. Hospitals are resilient, innovative, and deeply rooted in their communities, but they cannot sustain access without stable policy, fair payments, and that we address the workforce solutions and the continued state of federal continued and I should say continued state and federal investment in rural hospitals and in rural healthcare.
Fantastic. Thank you, Tracy. And yes, we will definitely be talking about the transformation funding later on. So just a tease of that there. Kim, I want to go to you and just get your perspective on all of this. Just kind of what do you see as the current state of rural healthcare in Illinois for rural providers like yourself?
I think the thing that we see the most are gaps in care that um, come from basically the logistics of where different healthcare sources are located. We're in 16 different communities in Southern Illinois, and some of the communities we're in have hospitals, others do not. Others travel a great distance to get to a local hospital. But what we see is a lot of transportation needs. Our population in Medicare is growing, and as it grows, there are more and more elderly people who are unable to travel outside of the community that they live in. Then we see a lot of Medicaid patients who don't have the means to travel outside of the community that they live in either. And so there are a lot of gaps in the resources that they can actually tune into. And so we try to reach them as closely as possible. Specialty care is a big issue for us as we see specialty care going out further and further distances from where the people actually live in Southern Illinois. Some of them have no means to travel to St. Louis or Evansville or Cape Girardeau or, Springfield. And so they go without a lot with being unable to reach those. I think telehealth has been a crucial component for all of us to be able to tap into, and we utilize it as much as we possibly can. Um, we also see a growing need for behavioral health services and, particularly substance use disorder treatment. And we provide those things within our organization. But what we see a great need from the hospital side would be the ability to admit patients with acute behavioral health needs. And there just aren't very many resources in Southern Illinois for the people to tune into that.
Absolutely. Thank you, Kim. Molly, I want to go to you on this one and just from the public health, perspective, just what is the state of rural healthcare here in Illinois?
Yeah, I think rural health is under sustained stress. I mean, in general, our budgets are smaller. Our ability to have maternal deserts and large behavioral health gaps in our communities is high. We have transportation to healthcare concerns in general. It just takes longer to get to services, lack of dental access to healthy food options. Long waits for those visits as well. Insurance covering not covering available clinics in our communities as well. When hospitals close, it looks like death for acute conditions, injury, heart attack, strokes, meaning not every place in America has the same right to survival. So rural centers, it is important to advocate and continue on advocating for our needs. Transportation has been a huge issue, especially finding mental health and behavioral health services for our community. Speaking to substance use disorder is clearly seen as an epidemic in rural communities without access to care. Generally, there are not as many behavioral health providers as well. So there's a lack of workforce available. As we see, the baby boomer generation retiring and leaving, that's about 5,900 daily workforce leaving, and estimated at 14.8 million by 2029, meaning that the ratio of millennials to baby boomers is about 5 baby boomers to 2 millennials. the workforce in rural communities is limited. There's a vast number of large agencies promoting high paid wages, where in rural communities we cannot afford to maintain those budgets based on our ability to maintain services and generally our budget allowances.
Definitely. Thank you, Molly. Dr. Fleck, I want to go to you and just kind of get your perspective on this. Just kind of where you sit, where do you see rural healthcare in Illinois?
Well, rural healthcare sits at the crossroads between excessive obesity, childhood poverty, teen pregnancy, chronic disease rates in rural compared to suburban and urban areas, and they're too high in every of those domains, but it's even greater in that area, in the rural area, with a workforce that doesn't always match it. So population supply of physicians, primary care doctors, there's a metric where, and this is something we're very interested in really trying to enhance the pipeline or workforce. Roughly 3,500 population per primary care provider. In the state of Illinois, it's probably overall about 1,300 to 1, so it looks pretty good. But when you go into certain areas, in rural areas, that number is 9, 10, 11, 12,000 to 1. Okay. In places like Cass County, Johnson County, or Jasper County. And so you've got this big imbalance of high disease rates and disease burden and inadequate supply of practitioners. Telehealth is big, and we certainly have embraced it here at SIU, and and I keep my fingers crossed that we will continue to be able to provide telehealth services like we do inpatient services with minimal restrictions. You've got 80% of the counties in Illinois don't have a child psychiatrist, okay? Which is insane. You've got counties where the average age over close to 60% of their surgeons are over 55 years of age. To me, primary care is where it starts. Doesn't necessarily end there, but Illinois right now is short by about 500, 600 primary care physicians to be able to get rid of its shortage areas. It's been alluded to, the changing landscape with federal funding is going to certainly have an impact. When I moved here from the Detroit, Michigan area just under 11 years ago, in our system here at SIU, when I would sit and look at our practice plan reports, our uninsured rate was 7%. With the Affordable Care Act and expansion of the Affordable Care Act and getting about 3.5 million people in the state on it, our uninsured rate's gone down to under 1%. But we are recoiling with the expiration of subsidies and work requirements, variety of things that's going to basically thin those rolls. And so our numbers are going to go up of uninsured. Well, the rural hospitals are already under stress. You've got probably a huge number of them, 30, 40% of them running probably in the red. They're running on razor thin margins, and this is going to further stress them. So here at SIU, besides talking about the problem, identifying the problem, as chair of population science and policy, one of our goals is to really address the workforce issue, and we're doing that by doing a detailed data dive, writing white papers, and going to disseminate this and propose some solutions on how to really enhance the workforce available to take care of people. So it's a tough time, but tough times tend to bring out our best in creativity, and we're going to need every bit of that here to take care of our rural problem in the state of Illinois.
Fantastic. Thank you so much, Dr. Flack. Dana, I want to go to you. Just what are some of the challenges and issues that HFS has identified, when it comes to rural healthcare? And maybe what are some of the, kind of going forward, just what are some of the initiatives and efforts that you're looking at, when it comes to rural health?
Sure. Thank you so much. I mean, the experts here at the table really highlighted a lot of what we see. They did a very good job covering the gamut from the, chronic disease burden all the way to the health professional shortage issues to the hospital solvency issues that we see. And so all of those are very concerning to us. So Illinois Department of Healthcare and Family Services, the Medicaid agency for Illinois. And just to give you an idea, we know that the rural health system relies heavily on Medicaid in counties classified as fully rural by the Federal Office of Rural Health Policy. The Medicaid enrollment rate is 19.1%. This summer, I was recently at a panel down in Du Quoin, Illinois. It was in Perry County. And just to give you a sense, in that county, it's 25% of the people living in that county are on Medicaid. So that gives you a good sense of one in four people in Illinois rely on Medicaid for health care. And as the Dr. Flack just kind of started to talk a little bit about as we head into the future and some of the changes that we anticipate through HR 1, many of those people will have to act to keep their health care in some way with the imposition of work requirements and things in Medicaid. And, we will at the state, our goal is to keep as many people insured as possible. But, I do think that uninsured rates are vulnerable to growing in these communities, and we're very concerned about that. So it is more important than ever that the Illinois Medicaid agency have a very strong partnership with all of the stakeholders here at the table and every rural hospital provider and those that are serving the hospital provider community, including our universities who are educating those who can take this on. We can go into a lot of different details related to the rural health transformation program, but essentially the federal government with the changes to HR 1 did recognize this vulnerability in rural health areas specifically and did provide an opportunity for states to apply for what is somewhere, we don't know exactly how much Illinois will be awarded, but somewhere between 100 million and 200 million a year to serve rural communities better in light of the changes that are coming. And so this has actually been a really remarkable opportunity to partner with the folks at the table. We can talk about stuff we've been doing directly with them, but also just to really take a look at the landscape and what it needs. And in the process, we heard from stakeholders across the state. I think ultimately we ended up we conducted like 38 one-on-one discussions, had public listening sessions with 300 attendees, received over 120 public written comments, and held about 46 follow-up conversations. So we were, since the bill was passed, have really been digging into the needs here. And from that, we built a proposal that we think will really dig into some of the biggest issues here. One is really supporting the providers in these areas by helping them transform their operations in one way or another, either at hospitals or FQHC or community behavioral health clinics, working on team-based care, moving towards value-based care where payments can, there is some achievement of quality within that, but that payments are more predictable and can increase over time. We're at the hospital level, any sort of practice transformation, adoption of technology, things that can really make their healthcare models more sustainable over time. That's something we're investing in. The other thing we are heavily investing in, you heard from a lot of the panelists so far, was really overcoming geographic barriers to healthcare. These transportation and other geographic barriers are critical. We are looking at it from two perspectives. One, increasing access to transportation itself and place-based care. So looking at building out mobile units, supporting our EMS system. So more, we can support more paramedicine, treatment in place where, when an EMS responds, they can treat at somebody's location and if they don't need to be transported. Those kind of things are something that we're looking at. And then the other big piece of this is expanding access to telehealth and other technologies that make healthcare accessible in place for individuals, particularly specialty care. I mean, the mention of the child psychiatrist issue in 80 counties of Illinois is a great example that is the type of care that we can make accessible from an institution that may be in a metro setting, but make that specialist accessible through telehealth in a rural area. That's huge for this application that we submitted. And then the other very foundational piece that we are looking at is how we can build a resilient workforce. And this is at all levels. I mean, I think that there's scholarships and apprenticeships and others that can support, you know, nurses or doctors or MDs, but we're also looking at entry-level workforce positions like community health workers, peer support workers, where we can expand those populations. All of those are like now billable through Medicaid, so those are billable services. Expand those like frontline healthcare workers and that workforce, because often those that enter healthcare professions at that level then go on to educate themselves to become nurses or doctors or other things later in their career. And so we're really looking at those career ladders and building this out as much as we can. And we're grateful for our partnerships with SIU and other institutions, educational institutions in the state of Illinois that will help us through this. So that's a taste. I can go into more detail as well.
Wonderful. Dana, I think you answered about 4 or 5 of the questions I had lined up for you.
Oh,
So
sorry.
that was a wonderful job. You know, let's before we kind of get into some of the federal changes, some of them, let's stay a little more optimistic for a little bit here. And Tracy, I want to go to you for a little bit. We've talked about, yes, there are challenges, but there are opportunities as well. There are chances here for partnerships, collaborations of that nature. And I wonder if you could just tell us a little bit about some of the steps your members are taking, some of the innovations they're taking in order to address some of these challenges.
Oh, sure. I mean, definitely. And I think there's lots of good examples. The mantra, if you will, of ICANN has always been better together. So the concept of collaboration and connecting not only to each other, but to their communities. So, some of those examples that come to mind, for example, are on workforce. One of the hospitals is actually, as a retention tool, supporting their employees in obtaining car loans and housing assistance for down payment on a rent or a deposit, I should say, or down payment on a hospital. So that was something kind of new of like, oh, wow, that's great. If you can't get to work, if you don't have reliable transportation, you're not going to get to work. If you need to leave the community, then chances are you may need to find another job. So stepping back and looking at some of those more innovative concepts as it relates to retention in that case. But one other area that I think is really exciting is just the number of partnerships that hospitals have had with their schools and the athletic departments, for example, and supporting the athletic teams with athletic trainers and physical therapy or, after game sports injury type of walk-in clinics that are a community service that they make available to those athletes and their families, or during the summer having plots of land available for growing fresh vegetables. And if members of the community aren't doing that, I know of one hospital that they planted a garden, the staff did, and they would tend and harvest those vegetables and donate them to either food shelters or at a farmer's market. So there are campuses that have very complete wellness facilities. The idea being that rather than think of the hospital as a place to come when you're sick, you need to go also, or replace that concept with the idea that I'm going to go there to stay well, and create that connection to health at that level, as well as some of the back to school type events where physicals are offered, or there are forums where the kids come into the hospital to get back to school supplies and physicals and vaccinations, and get exposed to different departments within the hospital, like physical therapy or pediatricians that they typically are seeing when they're injured or sick. And so it replaces that fear with, this is where I can be and be well and be comfortable. And the hospital's presence in the community as a wellness entity as well. And it doesn't have to be all about going there when you're sick. So a couple of examples there that just come to mind as far as some more, innovative or more different approaches that we're seeing, other than providing, an ER or healthcare services when they're needed, when someone is sick or injured.
Fantastic. Great. Thank you. Kim, I want to go to you on that. Just what are some of the things that your organization and other health centers can do in this space? What chances are there for, opportunities are there for innovations, collaborations?
I think for innovations, it has a lot to do with the electronic health record format. There are a lot of savings in electronic health records where we can reduce the burden of manual functions that a lot of the staff are doing, that nurses, it takes a lot of time for them to do some of those things that could actually be carved into the electronic health record system, but it's very expensive. So for every tool that you add to electronic health records, it costs a little bit more. But as far as the collaborative piece of it, I think that the gap, the issue that we see are our hospitals do a lot of great things, and health centers are we're in the primary care world. We're not in the emergency medicine world, and definitely not, in most of us do not provide any specialty care. So um our biggest goal is to make sure that as the primary care hub for that patient, that all of their information, we have it recorded in that chart. Sometimes getting that information from some of our hospitals is very difficult because they're on a different system. There's no infrastructure that links us together, no interfaces so that we can send and receive that information. And that's probably one of the biggest barriers, I think, to that, our ability to work together. As far as the specialty care goes, if we can do telehealth between our sites and a specialty care service in a hospital, that's like the perfect world for us, because getting our patients to be transported to some of those locations is really difficult. And I think as far as uh, expanding some of the functions that we do, it takes everyone, and, especially public health, because what we find in rural areas are we are actually serving 1 in 4 residents in the rural areas for FQHCs. And so that's a big chunk of the community. But what we find, there is a lack of understanding about what healthy living, healthy lifestyles, what it's going to take to maintain their health. There's a big gap there. And public health serves that function for us just incredibly, but we have to figure out a way to get patients to pay attention to that, because if we get them and they're already suffering from hypertension and diabetes, we can't backtrack on diabetes, but we could certainly work toward preventing it with some of our younger patients. And that is definitely a hurdle that I think all of us could work together to try to improve.
Fantastic, great. Molly, we just briefly touched there on public health, and so I want to get your perspective. Just kind of what are some of the projects that Greene County Health Department is taking to address some of the challenges, and what more do you see in the collaboration space to address some of the challenges of rural health?
Sure. I started in February 2020 as the public health administrator in Greene. And at that time, I started and several of our staff didn't even have email. The cost of email was a concern for our budget. That is where rural health stands, is that we can't even have basic technology because we are concerned about our budget. Overall, we've done a lot of innovation since then. Staff have email, but we also have been really seeking community health workers, peer support services, navigating those sections of up and coming sources of assistance to people. It has been phenomenal in our community about assisting with transportation and getting people places and working individually with goal setting. However, navigating funding, navigating Medicaid reimbursement, and how we've actually get reimbursement for this is difficult. We don't have the staffing, the ability to, set forward somebody to take this on. We are just basically meeting the needs of our community and doing it at no cost. Um, you know, it is definitely a struggle. In general, public health departments, we are already 70% of the local health departments are coordinating and sharing services. We're working towards, access, but we also are a low-funded Illinois state as far as our public health goes. $231 per capita, which Illinois is ranked 40th among the states similar, even compared to District of Columbia. They fall short of the nation where they're spending $422 per capita on health. So we're one of the Illinois ranks the lowest among peer states similar. In general, in the Marion region, we have about 40,000 people that have left the area since 1960. We have an aging population. We have low and poor compared to other states. So this is devastatingly affecting our community, and we have to strive for innovation such as those community health workers and looking for ways to immediately make impacts because it is devastating.
Thank you. Dr. Flack, where do you see, this going as far as innovation, for rural health? And, what kind of collaborations can there be between these different organizations and, an institute like SIU School of Medicine? Oh, looks like we still have you on mute here, Dr. Flack.
So try not to be repetitive. From our vantage point, thing that we are really most interested in trying to do is trying to figure out a way to address the pipeline issue. And so here's a medical school. We have students. We graduate roughly 70, 75 a year. Our kids get out of school. They've got $200,000-$300,000 worth of school loans. We started a program here in our Department of Medicine, where I'm chair, where we identify people, and they identify us as saying, "Hey, look, we'll come to work for you in the FQHC, in the ambulatory FQHC. We'll sign with you now, even while we're in our training." And what we actually do is call it the Aspire program. We actually supplement them a couple of $1,000s a month over and above what they get paid as residents, and give them sign-on and 3-year retention bonuses and a competitive salary in the FQHC. I think that there is a need for things like this much greater than what currently exists. And there's some federal programs, so like if you go to work in the FQHC, you can get loan forgiveness. But I think there are also some things the state of Illinois can probably do. And we are laser focused on working with anyone and trying to develop programs to really enhance that pipeline. And certainly primary care doctors are a central part of that, not the only part, because nurse practitioner, nurses, MAs are important as well. But I think at SIU, that's something that we are very interested in beyond just delivering care. I mean, our catchment area is 66 counties, roughly 2.2 million people, and a lot of it is rural/small town who comes to see us come hours away, and a chunk of that has to do with their providers who simply do not take in their clinics Medicaid. Okay, I'm fortunate to work in a system where we see everyone, and all. We don't screen them out of our clinics or anything along those lines. And I think another thing that we forget when we're talking about Medicaid is that 44% of Medicaid recipients are children, not adults. They're children. Almost 70% non-disabled adult Medicaid recipients have income. And a number of people actually work in jobs that don't have benefits. They're not, they don't have jobs where it gets them out of qualifying for federal nutrition benefits and other kinds of benefits and all. And this sort of mindset that we're going to make you go to work. We're the only industrialized country that hasn't quite figured out that healthcare should be broadly available and right, not a privilege, and not just because you have really good insurance like I do and all. So long-winded answer to say here at SIU, and I know here in population science and policy, we are dead set focused on doing our best to try to partner with anyone to come up with innovative solutions on this pipeline issue. And us being a medical school, we're certainly part of the pipeline.
Thank you so much, Dr. Fleck. Dana, I want to go to you and let's get into it. We kind of talked a little bit about it before, but there's been a lot of headlines and discussions about the federal tax and spending law that Congress passed this summer and what impact it will have on Medicaid and other healthcare spending. And I'm just curious from HFS's perspective, just what do you see as some of the major impacts that this law will have on rural healthcare in Illinois? Dana, looks like we still have you muted.
Thank you. As we know, the federal cuts that are happening as a part of that bill to Medicaid will certainly have a widespread effect across Illinois on all areas. But in particular, rural health, even with this concept of a rural health transformation, infusion of funding will have, very detrimental effects. Illinois, we estimate that over 270,000 residents could lose coverage across the state due to the imposition of both more frequent redeterminations through Medicaid and through work requirements that are being imposed as a part of the program. And we're looking at this as a potential $6 billion loss through other measures that are coming to the state of Illinois that affect hospital payments and things that could really have a detrimental impact on rural health providers. Of course, getting granular to Illinois, we know that effect will reach rural health, and nationally, Kaiser Family Foundation has looked at what this impact that will have on rural health providers across the country, and they anticipate rural health will lose upwards of 137 billion from the HR1 bill, which is nearly 3 times the 50 billion that was allocated in the fund, indicating that, we are going to have to really partner with rural health to mediate the potential harm that some of these new requirements can cause. But we are going to be our goal at the state of Illinois with HR1 overall is to reduce harm, ensure that we can keep as many people enrolled in Medicaid as possible, and also to keep as many services as possible running despite these cuts. So we are thinking very creatively in a lot of ways. Our HR1 implementation process really looks at ways that we can ensure the largest number of people that can somehow be exempted from having to do this increased burden of work requirements can be based on maybe they are medically fragile or if they have some sort of exempting criteria. We'd like to make sure our technology can do that automatically, that folks can then just remain insured in the program. And then for those that have to act and actually do need to do something to assert their employment, we want to make our interface as easy to use as possible. We are going to partner with community agencies, with MCOs to allow people to understand how to use the system, who, if they're affected, what are they required to do to take action, and make our staff available to answer questions and walk people through this as much as possible. So we, in that regard, we are really focused on keeping people enrolled. That will help the finances of our rural health providers in the meantime. But some of these other cuts that are happening to the funding that we are able to distribute through Medicaid, I think that's going to be some hard questions, and it affects the state budget. In state fiscal year 2024, Illinois received $20 billion from the federal government for Medicaid spending across the state, which made up about 62% of our total funding for Medicaid programs in Illinois. So we really rely very heavily on this partnership with the feds for this. And so we're going to be thinking creatively. We're going to be partnering with you. That's why we're moving rural health towards some of these innovations like value-based care that's really paying for whole person health. Keeping people, investments in primary care are going to continue to be very critical because the more we can keep people engaged in a medical home, the less likely they are to face a critical condition that would, cost the system more and more as we move forward. So we have our work cut out for us, let me tell you, but we're ready to do it, and we're going to do the very best we can to reduce harm here.
Definitely. Tracy, I want to go to you on that. Obviously, Dana laid out some of the challenges that are coming from, cuts the Medicaid, the cuts in the provider tax revenue. Just kind of how do you anticipate this affecting rural hospitals?
Oh, well, I think that's been covered really throughout. It's a negative impact with declining reimbursements, more effort to obtain payment. Medicare Advantage is a challenge for our members to get paid on a timely basis or to have to jump through hoops like prior authorization. All fewer insured people and folks come into the emergency room because they don't have coverage and they've delayed seeking treatment, and it's more costly at that point, and a 24/7 ER and what that provides in terms of access also is uncovered and uncompensated care for our hospitals. So that will add to the burden as well. So I think that's all been alluded to in this conversation of then how do we ensure that policymakers know, and both at the state and federal level, when we have such a significant percentage of our rural hospitals are reimbursed by the two programs combined, that we really have very, very little control over, and it seems to be at the discretion of Congress whether they're going to cut healthcare reimbursement or not, or support healthcare on the other end of the pendulum. But we have almost 30% of rural hospitals that operate on a thin or a negative margin. So that's where we stand today, coming out of COVID, where there were funds to support operations related to COVID care. and not having that money available, and then adding more changes on top of that in terms of policy and eligibility reductions, and some of the payment policies or changes in the payment policies that will reduce payments. So it's creating a pretty dire environment in terms of where our rural hospitals can be financially. The challenge of a rural hospital is the low volumes, and we have these standby costs, if you will, that are there consistently. To have a 24-hour, 7-day a week, 365-day a year hospital emergency room, you've got those inherent overhead costs, if you will, already built in, and not the volumes to really spread that across, to look at kind of a per unit, not to dehumanize it, but a per unit type of a cost, where a larger hospital has more volume, and also has a different payer mix, where they can have a somewhat of an impact on what that reimbursement would actually end up being. That's not so heavily dependent on the public payers, Medicare and Medicaid. But having those costs that are inherent regardless of how many patients you see adds to that cost, and people want the hospital, they want the ER, they want the OB care, they want the specialty care, and having some understanding that our hospitals are not making these decisions easily to say we can no longer provide OB care, we can no longer have the specialty clinic. It does come down to finances and reimbursement and availability of specialty providers. For example, an OB or an FPOB that is willing to take call to deliver babies at a rural hospital, when there may only be one other provider that is willing to do that. The reality of, and Dr. Flack can add some more specifics of this, is that it takes a minimum of 4 physicians, whether or not that's an OB or family practice that delivers babies, to have that continuous 24-hour, 7-day a week coverage, to have a hospital that delivers babies. And you add on top of that anesthesia costs and surgery costs, because you have to be prepared for a C-section whenever that may occur. You have that all built in, regardless of how many births that you're doing, or in the case of the emergency room, how many patients you have there.
Good point. Thank you, Tracy. Kim, I want to go to you and kind of a two-parter. One, obviously, just kind of what is your perspective on how the changes at the federal level may impact, community health centers like yours, and just as we talk about this transformation funding, just kind of what would be some of the things that you'd like to see these funds be used for?
I think that probably the most important thing that the funds could be used for is to really secure and validate some of those services that are essential in our areas in Southern Illinois. And I think our ability to get patients to the services that they need, the transportation issue is absolutely critical. I mean, there are no public transportation services in most of Southern Illinois. And, that is just years ago when I started in healthcare, that wasn't an issue in Southern Illinois, because most people could afford a car and they could afford gas. And today that just simply isn't true any longer. And like I said, the growing number of elderly patients that we have, who they feel comfortable driving in small communities, but they do not feel comfortable driving in larger communities where maybe they have to go to seek specialty care. But I think that basically, if we have to secure the infrastructure, and we have to work smarter, we have to have the skills of people to fill those positions. And I think that it's doable if we have the resources to do it. And I think, we all partner together. We work with SIU on training. We train our own CMAs within our health centers. Most of us do today train our own CMAs. But I think that there are so many things that are being affected today, not just with the bill, and not just with transformation, but for example, health centers. The other crisis that we're going through is the 340B drug pricing dilemma. There are no protections for health centers for our contract pharmacy business. And, I think that it goes without saying that without the proper medication, patients are not going to maintain or improve their health. And those benefits, that 340B program helps us to deliver medications to our patients at a reduced cost. And we are losing that in leaps and bounds every day because the pharmaceutical companies are stopping us from getting that. And it's not just FQHCs, it's the small hospitals as well are suffering from this issue.
Absolutely agree. Molly, I want to go to you on just kind of this conversation that just what would be some of the things that you'd like to see some of this transformation funding be used for to support public health?
So I think it's so important to realize that the transformation funding is needed to be more than 1 year of funding. We can't actually make any specific differences if we only think that we have 1 year to fund a workforce position. Knowing that we have 5 years in this, we could really make strides. And I'm very optimistic in the fact that there could be funding for behavioral health and generally substance use disorder and transportation, but it has to be long term and designated. Also, I'm just knowing that we are a small fish in a really big pond. It is important that we are funding the rural community itself and not neighboring communities that say they're going to provide these services and then don't. I've seen that many times in our community, and it is so important that that funding goes specifically to rural centers. In general, there was mention about mobile units. That could be a great idea. However, that's what an example of how we might say that we're going to go to that rural community and then don't. So I really I have optimism for the funding sources. If it's long term and identifiable that we can actually provide workforce for a longer period of time, there will be significant change in the ability to serve our communities.
Absolutely. Dr. Fleck, I want to go to you, and I want to switch gears a little bit because we're rapidly running out of time here. But I want to go to something that was mentioned a little bit ago, and it wouldn't be a healthcare discussion without some discussion about AI, telehealth, and just kind of virtual care and, what that could mean and the potential of that. And I was just curious, just kind of get your perspective on that. Just what opportunities do you see in telehealth, digital health to address some of these challenges faced by rural patients and providers? And then maybe also just what are some of the limitations that these services provide, have?
So telehealth, again, we do a lot of telehealth here. We did a massive amount during COVID. And the idea, and I think we've been a reliable partner for providing services to people outside of our market and haven't really left people standing. And so some of the healthcare delivery, the expertise may not necessarily reside in the rural area. And so if you have reliable partners, you're going to be able to access some of that expertise through virtual platforms and telehealth. So having unfettered access to telehealth, being able to get reasonably reimbursed for telehealth and all over time, I think is going to be really important. The area of artificial intelligence, that's fascinating. And we're actually doing a project now where we are using machine learning and stuff to actually help us optimize our scheduling of patients in our clinics. And we have had some pretty good estimates about how by using smart staggered scheduling that we can actually drastically improve time utilization. Because when I just left clinic, and sometimes I'm sitting in clinic, and if I don't overschedule, I may have 2 new patients scheduled early in the morning and still be waiting at 9:30 for someone to show up. And we're actually, again, using machine learning, artificial intelligence to help us to figure out how to adjust our templates. Epic, we're converting to Epic, and Epic has gone big into AI. And in fact, you can have a visit, and the actual program listens to the visit and generates a start of a note. I'm a little old school, so that's a little bit too much for me. And all, I don't want a machine generating the note. But one of our trainees, for example, a while back, did a discharge summary on AI and just about freaked our compliance people out because he sent it to me and they just about freaked out. And I said, this is probably one of the best discharge summaries I've read in a long time. uh, and I think what's going to happen as well is some of the burnout we're dealing with and some of the work that the EMR puts on people. AI has the ability to help mitigate that. Okay. So I am skeptical of some aspects of it, but I'm actually hopeful that, for example, it will really help us reduce workload and burnout, because anybody who works with the EMR knows that the EMR generates a massive amount of after visit sort of visualizations and clicks to check all the boxes you need to.
All right, Dr. Black, thank you so much for that. We somehow only have 2 minutes left in this discussion. It kind of really flew by today. So I do want to go to each of our panelists on this. And Tracy, I'll start with you on this and we'll go down the row. But in about 30 seconds or so, I wonder if you could just look into your crystal ball and just tell us, what do you think rural health is going to look like in 5 to 10 years here in Illinois?
Well, crystal ball, and certainly my hope is that it is not just surviving, that it is thriving with an investment and with attention given by policymakers and legislature and Congress, that realization and recognition that rural health is some of these assaults that have occurred with the funding and policy changes are not just assaults on rural health or assault on rural life altogether. Because I mentioned some of the hospitals, that many of our hospitals are the cornerstone of their economy. And if that hospital is no longer in existence, what that does in terms of not only access to services, but you have jobs that go away, and people that work at the hospital, are eating locally, shopping locally, all those kinds of impacts that have if you lose a workforce of several hundred people. So my crystal ball is saying that with collaboration and with support and recognition of the importance of rural healthcare, not only in Illinois, but across the country, that we will continue to have good access to high quality care and a healthcare system in rural communities that is looking at not only illness, but is looking at and being recognized. And that means being reimbursed or compensated in a way that rewards care that's not only for sick people, but care that keeps people and services that keep people healthy and away from healthcare providers.
Fantastic. Kim, in about 30 seconds, just what do you think rural healthcare is going to look
Yeah.
like in Illinois?
I think that Southern Illinois and rural Illinois, we have a lot of smart, innovative, caring, and committed people that are willing to do what it takes to make the lives of our patients better. And I think if we work together, we can make that happen with the proper foundation, which is, of course, the funding.
Fantastic. Molly, what about you? In about 30 seconds, what do you see as the future of rural health in Illinois?
I believe we're persistent and definitely resilient. I believe there is innovation need for survival, and in general, I'm very hopeful for behavioral health access and general transportation access as well.
Fantastic. Dana, what about you? Where do you see rural health in Illinois moving forward?
I think that with an investment in Illinois and this transformation that will modernize the workforce, modernize our healthcare delivery systems, we're going to use all the tools in our toolbox to ensure that people are getting care where and when they need it. and that we're able to actually improve health outcomes over time. And I also envision creating a health system through some of these deep investments we're going to make that health the health system actually also is an economic driver for communities in rural areas and really continues to be the lifeblood of a lot of these communities over time. So that's our commitment at the state of Illinois.
Wonderful. Dr. Flack, I'll let you have the last word. Just where do you see rural health in Illinois moving forward?
See it innovating and tapping into our collective creative ideas, juices, collaborations on the delivery of care, how we augment the pipeline, how do we attract practitioners to go, relocate, and stay in rural areas. And I think there's a lot of fertile ground there that if we work together, we can figure out.
Fantastic. Thanks so much to our wonderful panel for joining us today, and for all those who joined us on Zoom or on our YouTube page. This is our last event of the year, virtual or in person. So I want to thank everyone who supported Health News Illinois through the year, and I want to thank you again, and I wish you all a wonderful holiday season. Thank you so much, everyone.